Hello, I'm Peyton Stockland, and we have a presentation on disruptive mood dysregulation disorder. This disorder was added to the DSM-5 in 2013 to help differentiate bipolar disorder among the youth. A quick definition, it's basically severe irritability resulting in verbal and or physical outbursts, not tantrums. It's very severely out of proportion to the situation and very persistent. Example, 8-year-old brought to the family nurse practitioner for about 18 months of just being angry all the time, persistent outbursts, things as simple as telling the child to stop playing a video game. It causes a huge irritability, very aggressive verbal, physical outbursts towards parents. This will also be seen at school. Teachers will complain about these same symptoms. Usually it has to be after 6 years old to diagnose this. And this is the criterion. There's a whole list of things. This thing is it has to be between 6 to 18 years old when they can diagnose a child with this. And some highlights, that's at least 3 times per week on average of these outbursts. Family will say, my kid is not the same. A year ago, they were not having these outbursts or these severe outbursts, persistent, experiences, and they'll come and complain about that. Some big important rules. They cannot coexist with oppositional defiant disorder, cannot coexist with intermittent explosive disorder or bipolar disorder. If there is oppositional defiant disorder, the DMDD trumps it. And it can coexist with major depressive, ADHD, conduct disorder, and substance use disorder. And of course, the important one is it has to be between 6 and 18 years old. So you can't be diagnosing it before that. Prevalence, this is about 2.5% in population-based studies, with highest rates in the youth are being diagnosed with this. Males are prone to have this disorder more than females. Often you'll see depression, anxiety, and also part of it. The anatomy physiology, it is more of emotional regulations chemistry. So things like the structures like the amygdala, prefrontal cortex, these structures that help process emotional processing are the big influences on this. It's usually an increased activation of the amygdala, or this increased regulation disrupting the circuit of being able to control the emotional experiences. And of course, reward processing of cognitive networks are important, allowing the child to understand how to make decisions. Control of their emotions is a big part of this. Clinical assessment and clinical examinations, most of it's comprehensive physical assessment, so structured clinical interview the parents or caregiver and the child separately to get both of their sides of the story, identify the baseline, timeline of onset, duration, frequency, and intensity. And then also the mental status examination, do a thorough examination of the patient's appearance, behavior, mood, affect. Of course, most important is physical examination to rule out any medical problems like thyroid dysregulation, any head injuries, seizure disorders, substance use abuse. Neurological exam must rule out those medical issues first. Differential diagnoses, we got bipolar disorder, which is more episodic. It's not so persistent like it is with this disorder that we're talking about. Also major depressive disorder, autism, anxiety disorders. All of these are different diagnoses. And of course, management is mainly referral to behavioral health specialists for psychotherapeutic approaches. And to get the parents involved, skill training, patient skills training, dialectical behavioral therapy is also important. Medications aren't the first line, it's definitely later on. Usually has to be involved with other anxiety or depression disorders along with this, like SSRIs, stimulants, atypical antipsychotics. Prognosis is you catch it earlier, the better. Parents that are willing to work with the child and the behavioral health specialist is critical in order to help manage this patient's ability to control their emotions, control what they can control, and hopefully help them overcome this. Of course, increased education is important. And it's always a goal to help with family and social relationships with these patients. These are my references. Thank you for listening.